Hello, my name's Emma. I'm one of the pharmacists based at the Pharmacy Clinic. I'm the clinic lead there, and I like to see patients with complex needs, lots of medication, and we see patients for free. I want to talk to you today about a condition called osteoarthritis. What comes to your mind when you think of the term osteoarthritis? Well, most people would say pain, stiffness, joint disfigurement. None of those words are particularly warm and fuzzy. So osteoarthritis doesn't really make one feel very happy. What can I do to help myself? Well, being part of the SCOTS programme, the Southern Community Orthopaedic Triage Service, is a good way to help yourself. We hope to educate you about diet, exercise, how to use your medicines appropriately, and how to manage with things like pacing, mood, and sleep. Can you name a medication that is designed to reduce pain? Paracetamol, ibuprofen, diclofenac, codeine, morphine, gabapentin, celecoxib. There's lots of different medications that people are either prescribed, are taking over the counter, or have just heard of. There's no such thing as a painkiller. That is a myth. What is realistic is to have medication to help reduce pain. So say, for example, if your pain is a 6 out of 10, we might realistically get you to a 5 out of 10. That's clinically significant. But it's just about being honest about what's achievable with regards to pain and pain relief medication. Where would I look for information about medication? Use us. Most people would say Dr. Google would be the first port of call. And actually, you know, if it's raining and you're on your own and it's nighttime, you might want to look at Dr. Google. The key is to look in the right places. So medicines information, government-sponsored websites such as Healthify are really important. The New Zealand formulary is a good place to look. The key is not to look in the wrong places. So my truth is not the truth, and people do write about their own medicines experiences based on their own bias. It's not really a reflection of what's actually happening. Certainly, use pharmacists. We're on every street corner. We're free. You can walk in and speak to us. By all means, ask your GP as well. But if you're like me, you know you've only got 15 minutes, and the diagnosis is the key, really, in that space. Paracetamol is very effective for treating my osteoarthritic pain. Agree or disagree? Or somewhere in the middle? It might be that you find paracetamol really effective. It might be that you've tried paracetamol and you haven't found it effective at all. If you're taking it correctly, it can be a good baseline, and we'll talk about that in a moment. It's important to give you a bit of an overview of what medications are available. So over-the-counter medicines, such as turmeric, they did some clinical trials with turmeric. The capsules, they don't work at all if you just take them as capsules. However, the magic is in when you cook with turmeric, so putting it in a dal, having it in a chai latte. The anti-inflammatory qualities are activated when you cook with turmeric. So not big in pain relieving qualities, but they just add to that jigsaw puzzle of pain relief. Glucosamine and chondroitin is a medication you can buy over the counter from a herbalist. It is a sugar that helps maintain cartilage. The chondroitin part is the really important part. You need about 1,500 milligrams of glucosamine, about 800 milligrams of chondroitin. Now, the research shows that for some trials, this is helpful for pain in osteoarthritis. Some trials have said it's an absolute load of rubbish. So my advice to you is to, if you can afford it, and if you're not allergic to shellfish, that it's worth a trial. So adding in with some of the other medicines you might be taking. What I would suggest is that you keep a diary of what your pain looks like over a month's period. It might be 6 out of 10, 7 out of 10, 4 out of 10, and describe the pain. Do that for a month. Then start the glucosamine and chondroitin. Do that for 3 months. If after that 3-month period, there's no change in how you feel about pain, the pain levels and the pain type, resign it to history. If you do find it effective, continue to take it. There are also creams available from your pharmacy or even from a supermarket that help reduce or provide comfort for pain. So they're not pain relievers in themselves, but they do provide a bit of comfort, a bit like a wheat bag. Those might be things like ice tea or iced gel, creams and gels that have menthol in them that give the illusion of cooling, which can be very helpful. We also have capsaicin cream, which can be prescribed by your GP for a month with osteoarthritis. That contains chili extract. The design of that really is to irritate the skin when you rub it onto the skin. If it's your knees or your shoulders, you rub it on there. It provides warmth to the area. It's a bit like putting a wheat bag on the joint to provide a bit of comfort, a bit of warmth. Care does need to be required, washing your hands after you've used the cream, because it does contain chili extract. You put your fingers in your eyes, that could be very sore. So there are some creams that are available that provide comfort, but not really strong in the pain department. There are creams, of course, available from a pharmacy that do have active ingredients in them called non-steroidal anti-inflammatories. So those are things like ibuprofen, diclofenac, naproxen. They are designed to reduce the level of pain at the joint site. We suggest that these gels and creams are used on smaller joints, so fingers, maybe ankles, knees, that sort of thing. The difficulty with these gels and creams is that the dose varies dependent on how much cream or gel you put onto the joint site and whether or not you've just come in from a very cold Dunedin day or you've just had a very hot bath where the blood supply is quite significant. So if you have a hot bath and you put lots of cream on, you're going to get a big dose of the drug. If you have a smaller amount applied to a smaller joint and your fingers are, for example, very cold, you're not going to get much absorption at all. I always feel that it's better to work from the inside out rather than the outside in. So using these products would only really be useful if you had some significant heart or kidney problems. And I will talk about the non-steroidals, taking them as a tablet in a moment. Paracetamol. I love paracetamol. It's a great little drug. We use it for teeny tiny babies based on their weight. We use it as a pain relief source for people who have cirrhosis of the liver. So their livers aren't working anymore. And we use paracetamol as our pain relief of choice in those patients. Because that is something that people worry about with regards to paracetamol. You don't need to worry about paracetamol, provided that you don't take more than 2 tablets 4 times a day. So that's 8 tablets in 24 hours. That would be a dose for somebody over 50 kilos. If you're under 50 kilos, we base it on your weight. The key with paracetamol is that you need to take it regularly for osteoarthritic pain. So with osteoarthritis, the pain is constant, it's there all the time, it's exhausting, and having that baseline pain relief is really, really important. It's like the foundation of your house. So taking 2 tablets 4 times a day gives you that sort of baseline, which means you don't have to use the higher or the stronger pain relievers as often. Paracetamol does have some side effects. Interestingly, the most common one is headache, would you believe? So some people do experience headache with regular use of paracetamol. I acknowledge and understand that 2 tablets 4 times a day is a lot of tablets on top of tablets that you might already be taking for blood pressure, diabetes, epilepsy, something like that. So I understand that it's more tablets than perhaps people want to take. There is something called paracetamol osteo, which is not funded, but you can buy it from pharmacies, and I would suggest you shop around. And that has a modified release formulation of paracetamol. So you only need to take 2 tablets 3 times a day, so every 8 hours, instead of 2 tablets 4 times a day. And what I would suggest is if you're taking the paracetamol osteo, you don't take the normal paracetamol. Safety-wise, we would always say that with paracetamol that you, if you are poorly, like you've had a cough or a cold, that you speak to the pharmacist to make sure that any over-the-counter medicine you buy doesn't contain paracetamol as well, so you don't end up taking too much. Non-steroidal anti-inflammatories. Now, these include things like ibuprofen, diclofenac, naproxen, mefenamic acid. There's lots and lots of different non-steroidal anti-inflammatories with slightly different qualities. Celecoxib is one, which we often use for patients or prescribe for patients who've had a history of a stomach ulcer or a stomach bleed, because it's less likely to cause that as a problem. The reason that the non-steroidals cause stomach ulcers and stomach bleeds is for a couple of reasons. Number one is that they're acidic in their very nature. And number 2 is that they affect these fun things called prostaglandins, which affect the thickness of your stomach lining, which put you at risk of a tummy ulcer. You've got to be careful with these medicines with your tummy. So we often say to patients, when you're taking these sort of medicines, have something to eat. Having food in your stomach protects your stomach from these particular side effects, so that's important. These medicines are also not advised to be used for patients who've never had them before and have asthma, because sometimes that can trigger difficulty with the breathing. If you've had ibuprofen before and you've got asthma, then that would be fine. These drugs are also not friends of your kidneys. So as we age, our kidneys don't work as well. It's one of the joys of aging. But what we do know is the non-steroidal anti-inflammatories make the kidneys quite unhappy. Your kidneys are like the vampires of your bodily system. They love being perfused with blood. They're very happy when there's lots of blood in those kidneys. What these drugs do is they reduce the size of the blood vessels supplying the kidneys and increase the size of the blood vessels taking the blood away from the kidneys. So your kidneys are less well perfused with blood, and that makes them quite unhappy. Your kidneys are responsible for your blood pressure. And what we do know is that these medications can cause an increase in blood pressure. So when your blood pressure goes up, surprise, surprise, your heart isn't happy. So we always advise caution with the non-steroidal anti-inflammatories if you have heart or kidney problems particularly. Speaking to a pharmacist about that beforehand is really key. And there are some medications within the classes that have slightly lower risks than others, depending on whether we're talking about your heart, your kidneys, or your guts. The thing with non-steroidal anti-inflammatories is that they are fantastic at treating osteoarthritic pain. Really, really good. So patients really find benefit from them. So we like them, apart from knowing what the side effects are. And I think it's really key that patients have autonomy. So they know what the risks look like and they can make that decision for themselves. Basically, with the non-steroidals, because they work so well for pain, some patients take them a bit more often than perhaps we would advise them to. These medicines, we would suggest that you take them PRN, so as and when required. So the opposite of what we were asking you to do for the paracetamol. So taking the paracetamol regularly as your baseline, and then just using the non-steroidal anti-inflammatories as a top-up for when pain is particularly bad. Some of my patients have taken things like diclofenac or Voltaren when they know that they're going to go and do something they enjoy doing that gives them pleasure and fun and quality of life. For example, I had an 80-year-old gentleman who enjoyed water skiing. And so he would take the non-steroidal before he went water skiing, whilst he was water skiing, and just after he was water skiing, knowing what the risks looked like, but it enabled him to do those things that he really enjoyed. Sometimes patients take non-steroidal anti-inflammatories before they're going to see their physiotherapist, because your physiotherapist is your best friend when it comes to osteoarthritic pain. The exercises that they give you are really important and they really will be helpful. And this is very much a condition where there's no pain, no gain applies. So using those non-steroidal anti-inflammatories safely, carefully, and with the knowledge of what the risks look like is really key. Another form of pain relief that we have is tramadol, codeine, dihydrocodeine, morphine, fentanyl. Those sort of medicines are in the family called the opioids. Now, opioids are fantastic at relieving acute pain. For example, if you were to break your leg, the paramedics would turn up and they'd give you some morphine. And the pain would go, but you might feel sick and you might feel sleepy and you'd certainly be constipated, but the pain would be gone. These drugs are very good at treating acute pain. They have no place in persistent pain, so long-term pain, such as osteoarthritis. And the reason for that is the way in which they work. If you take them regularly, they cause tolerance and they cause psychological and physiological dependence. If you've already got osteoarthritis, you don't want another problem on top of that. Now, I'm not saying that you can't use these medicines, but using them responsibly, A, means you get best bang for buck, and B, means you're not going to have any of the awful potential withdrawal or side effects that you might get. So what I would suggest, again, like the non-steroidals, is if you have been prescribed these medicines, that you use them PRN. So treat yourself on a Friday or Saturday night so that you know you're going to sleep very well with them because they're sedating. Know that you need to take them with some laxatives because they're going to make you constipated, but know that it's going to help with pain, so that might help with sleep, which might help with how you feel about the pain the next day. Do not take them regularly. If you were to take codeine, 30 milligrams once in the morning for pain relief, that would be great. You'd be able to experience no pain, and that would work for a few weeks. But what happens is the receptors in your brain start to increase in number, and so you need 60 milligrams of codeine to get the same level of pain relief a couple of weeks later. After a period of maybe 2 or 3 more weeks, the pain returns, and you need to take 60 milligrams twice daily. And before you know it, you'll be on 60 milligrams 4 times a day, still experiencing pain, but no longer taking the codeine for pain relief, but for taking it for withdrawal relief symptoms. So coming off the opioids is quite horrific, quite horrendous, and people really struggle with that. So they're actually taking the medication and they're still in pain, but they're taking it because they're experiencing withdrawal symptoms. And that is a path that we don't want anybody to go down. It's a path that's very difficult to come back up. So we encourage the use of opioids occasionally if people really must take them. We would rather you have the non-steroidals and the paracetamol as the baseline, but we understand and acknowledge that pain is exhausting, and an occasional tramadol, an occasional dihydrocodeine, you're going to get the drug working very well if you take it occasionally, and you're going to get some pain relief as well. Not a lot of pharmacists like codeine. The reason that pharmacists don't like codeine is because there's a fun enzyme in your liver called cytochrome 2D6, which metabolizes codeine into morphine. Now, how quickly you metabolize codeine into morphine varies from individual to individual. So for me, example, I don't metabolize codeine into morphine at all. So I take codeine and all that happens to me is I get constipated. Pain relief-wise, does nothing. My mum, for example, she takes a small amount of codeine and she's seeing fairies and unicorns, and she's actually quite entertaining to watch, but it's quite frightening really, because she metabolizes codeine into morphine very quickly. Most people metabolize it at a reasonable rate, but the difficulty is that we don't know individual to individual how that looks. If you take it and you feel that it's helpful, take it occasionally. If you take it and it doesn't help at all, don't take it anymore. And if you take it and it causes some extreme side effects, such as hallucinations, I would suggest that you don't take it anyway. To be honest, I would rather patients be prescribed morphine than codeine, because at least then you know where it's a level playing field. So 30 milligrams of codeine is equivalent to about 3 milligrams of morphine. So if you're prescribed 30 milligram codeine, you're actually possibly getting 3 milligrams of morphine, depending on how quickly you metabolize it. Opioids, in a nutshell, handy to have as an occasional pain reliever, not to be taken regularly. There are steroid injections that you can have. Now, steroid injections are useful because they reduce inflammation at the site. So these injections need to be done under aseptic conditions. That means that we don't want to introduce any bacteria into the joint. Some patients have said to me that the injection can be a bit more painful than the condition, and the results vary very much from individual to individual. So the steroids are a bit like the steroid cream that you put on your skin or inhaled. It just reduces inflammation at the site. Some patients get as much as 6 to 9 months of pain relief after a steroid injection. Some patients might get 3 months of relief. Some patients, a week or 2. And some patients report that they don't get any relief at all. For those patients that don't get any relief at all, we're not going to give you another steroid injection. For those patients that maybe get 6 to 9 months of relief, the next time that you have an injection, the likelihood is that you will get relief again, but for not as long, so maybe 3 to 4 months. We don't know why, but what we do know is the first injection is the most effective. And you can only have so many injections in a year. The different steroids have slightly different licensing, so there are some injections that can be given more frequently than others, but it very much depends on what your GP is going to use. Lots of patients ask me about cannabis. The Cannabis Clinic will tell you that cannabis works for all forms of problems, any medical problems, it works. So being the pharmacist person that I am, I chose to go and have a look at some meta-analysis and some systematic reviews to see what the evidence said. And what the evidence says is that cannabis works really, really well for certain conditions, such as childhood epilepsy, such as nausea and vomiting in patients who are on chemotherapy or towards the end of life. What there is no evidence for is for osteoarthritis pain. And believe you me, they're trying to get the evidence, but there isn't evidence there at the moment. So what I find is important as a pharmacist is to be honest with people. I think that when people are in persistent pain long term, they get desperate and they're looking for a solution. And that's when people end up paying $280 for a small vial of cannabis oil that's not going to be helpful. So it's important that you understand that there is no evidence for pain relief in osteoarthritis pain with cannabis at the moment. If and when there is, we will let you know, but currently, as it stands, you'd just be wasting your money. Now, of course, there is the placebo effect. Your brain is a wonderful, amazing organ, and I have had patients in clinical trials who've said, oh, Emma, I got this side effect and that side effect and the other side effect, and then we've told them they're actually taking the sugar tablet. So the power of the mind and the power of the brain is very important. If you find that you've tried cannabis and it's been helpful for you and you can afford it, then that's your choice. What we do find is the cannabis that contains the THC, that's the stuff that gets you high, means that perhaps you don't care about the pain so much anymore, but the pain's not gone. It's just you don't really care about it so much anymore. And that's maybe helpful. The thing you've got to be careful about with cannabis is that you get the munchies. And so you tend to eat a bit more, which puts on weight, which can put on some pressure onto your joints, particularly osteoarthritic joints. And we're always encouraging people to lose a little bit of weight with osteoarthritis. So maybe cannabis might be counterproductive in that space. There are really good websites to look at to manage your own pain journey. And there is a really good one by the Durham University that is being written by patients who experience persistent pain. And they may part of it might teach you to suck eggs. So you might know about all of this stuff already, but there'll be some interesting bits. There's videos, there's bits to read, and it talks about pain in the brain, it talks about pacing, it talks about mood, it talks about relationships and how to manage setbacks. And it's certainly something that is there to help you use your autonomy in managing the pain that you experience with osteoarthritis. And that's it. If you have any questions and you want to come and see us at the Otago University Pharmacy Clinic, we're happy to see you. We've got a team of people that will see you for free, and we might have a cup of tea.